right, guys. I'm not very loud, so please let me know if you can't hear me. Um, for those of you who looked at the schedule and were wondering who Dr. Memmer is, that's me. All right, and this is my 5-minute toxicology case. This was based on a case that we saw recently, toxicology consult. So the case briefly is a 55-year-old male, history of prior suicide attempts, brought in by ambulance after he was found unresponsive in his apartment. He was found next to a mostly empty bottle of blue Benadryl capsules with blue emesis on him. He had a depressed GCS and his glucose was 78. On physical exam, he was normothermic, he was tachycardic, hypertensive. He was alert with his eyes open and no apparent distress. His skin was dry. His heart rate was regular but tachycardic, unlabored, normal respirations. He had normal active bowel sounds. On neuroexam, he was GCS 411, so his eyes were open and he was kind of staring into space, but unable to move any of his extremities to painful stimulus. However, later was noted to spontaneously move his left arm. He had horizontal and rotatory nystagmus at rest, but no hyperreflexia, clonus, or rigidity. His pupils were reactive and mid-range. His labs, just to kind of summarize it for you, were all pretty unremarkable. He had a CT head that was negative for any acute process, and his EKG of note was sinus tachycardia, but he had a normal QRS and QTC duration. I'm sorry I don't have that EKG for you guys, but it was normal. So his ED course, briefly, was at one point toxicology was consulted, and the patient was given Physostigmine, 2 milligrams IV over about 10 minutes. Per all the charting review, it was about 45 minutes till anyone noticed that he was improved in his mental status. He was alert, tracking, and mumbling answers to questions. So I'm not going to actually talk so much about this case and why or why not it fits with an anticholinergic toxidrome, but I really want to take the opportunity to talk about Physostigmine because in my 2 years of residency here so far, I had never seen this medication given before. And I think that it's important for you as the ED physician to understand why this medication is used and what are the potential complications of using it, because you may call a toxicologist and they ask you to give this medication, but you're potentially the only physician there in front of that patient, and you should know what sorts of complications could arise and what you need to be ready for, and who you should not give it to. So what is Physostigmine? It's a cholinesterase inhibitor, so it gets into your CNS and your peripheral nervous system, and it inhibits the breakdown of acetylcholine in your synapses so that you have increased neurotransmission at your muscarinic and nicotinic receptors. So the general dose is between 1 to 2 milligrams. You have to give it slowly, so at least over 5 to 10 minutes. This is per Goldfrank's. Some people even give a smaller dose than that. It's 0.02 milligrams per kilogram in kids. And it has a half-life of about like 20 minutes or so, but its actual duration of effect may be up to like 90 minutes. And it should be pretty quick acting. So you're expecting to see a patient respond to this within like 10 minutes. So if you notice that in our case, the patient wasn't noticed to be really having any change for about 45 minutes. So it's not totally clear whether or not this patient had true anticholinergic toxicity, or maybe there just wasn't documentation of his mental status, completely throughout, but that's neither here nor there. The potential uses for Physostigmine are in someone who may have overdosed on an antihistamine, or plants like Jimson weed, which are anticholinergic, and certain antipsychotics, specifically atypical ones like Seroquel, may have some anticholinergic effects. So just to briefly remind you guys, I'm just going to assume that you guys all know this. The muscarinic receptors are found in multiple places in your body, and these the gray circles represent kind of where they are, and so those are where you're going to see your signs of anticholinergic toxicity, because even though we're talking about anticholinergic, we're mostly in this kind of toxicology sense talking about the muscarinic receptors. And so don't forget that you also have them in your brain. So by giving physostigmine and increasing acetylcholine at all of these receptors, you're also going to be affecting the brain. And the reason that I wanted to point that out is because one of the main reasons that you would give physostigmine is to treat an anticholinergic delirium. The other anticholinergic effects, tachycardia, decreased bowel motility, urinary retention, those things aren't necessarily life-threatening, but a patient who is hyperactive, delirious, they're going to be fighting their restraints, they're going to get hyperthermic, and they're going to get rhabdo, and those are the more life-threatening effects. And so that's what I really want you guys to kind of realize, is that those muscarinic receptors in the brain are very important. So anticholinergic delirium is typically hyperactive, but they can be hypoactive in part of their time course. They can have pressured, incoherent speech, auditory and visual hallucinations. They're often like picking at things that may or may not be there. And interestingly, the CNS effects of anticholinergic agents can outlast the peripheral effects. So they may not necessarily have like the mydriasis and maybe not as much tachycardia, but they can still be altered and delirious. So why give physostigmine? Say a patient comes in agitated delirium, we see that all the time, we know how to treat it, we give benzos. But in patients who have overdosed on an anticholinergic drug, there are some pros to giving physostigmine as opposed to just benzodiazepines. So, for example, you're going to improve their anticholinergic symptoms, their tachycardia. You're going to improve their delirium because you're directly addressing the thing that is causing their delirium, their altered mental status. And there have been at least one retrospective study that kind of looked at the odds of patients getting intubated in those who got just physostigmine versus those who got physo plus benzos or just benzos, and actually the patients who got physostigmine alone had a lower odds of being intubated. You can use it as a diagnostic challenge. So say that you have a kid who comes in who may have gotten into something at home, they're altered, they're a little febrile, and you're thinking, I've got to CT this kid, I've got to LP them. If in the right clinical context, you give them physostigmine and the kid wakes up and is improved, and that may save the kid some unnecessary tests. And like I mentioned, primarily you really want to control their agitation. You don't want someone fighting restraints, getting hyperthermic, and getting rhabdo. And so there was another study, also retrospective, of course, that looked at patients who got benzodiazepines and patients who got physostigmine, and they found that there was much more improvement in the amount of agitation and decrease in delirium in patients who got physostigmine alone in a shorter recovery time. And it was the difference is pretty large. It was like 90% who got physostigmine had much more improvement in their agitation versus like 25% with the benzos, which is kind of surprising. But again, it's kind of like retrospective, so cause and effect can't really, or direct causation we can't really say. But there are also many cons to giving physostigmine, which is one of the things that I wanted you guys to really realize and be aware of if you're giving this medication. So it's short-acting, like I mentioned, so you may have to redose it because the drug or whatever they took may last in their system longer than the physostigmine. You can overshoot, so you give them too much acetylcholine, they become cholinergic, which could give them bradycardia, bronchorrhea, bronchospasm. So in patients who have a history of asthma, you can put them into an asthma attack. It's proconvulsant, so it lowers your seizure threshold. So people who are having seizures from whatever tox thing they ingested or have a seizure history, you can give them seizures. And then there are these infamous cases of patients who've actually had cardiac arrest, and these were in like the late 70s. There was a case series of 2 patients who had very large TCA overdoses, and they went into status epilepticus. And back then, they actually used the physostigmine to try to treat status epilepticus, which, as I just mentioned, is not a good idea. And both of those patients rapidly became bradycardic, were given atropine, and then had cardiac arrest. So nowadays, generally, we don't get physostigmine for TCAs. And then there are a lot of cardiac considerations that you guys should think about, which I'm going to mention here in a second. So consider physostigmine if you have a patient with agitated delirium or anticholinergic signs and you suspect that they've overdosed on something. Generally would not give it for anyone who's overdosed on a tricyclic antidepressant because of what I just mentioned. No seizure history. Patients with asthma should not get it. And then if your patient is already bradycardic or has an AV block, you're giving them a lot of acetylcholine that's going to slow their heart down even more. And then your patient should have a normal QRS, a QT, and no tall R wave and AVR. Because you're slowing down their heart, you're potentially predisposing them to arrhythmias if they're already predisposed from potentially whatever toxin they ingested. And so I just wanted to show you guys what the tall R wave and AVR looks like. And that is actually because the right side of your heart's conduction system is more sensitive to sodium channel blockade. So that may be one of the first signs that you see before you get to your QRS prolongation from a sodium channel blocker. So that's just something to look out for. And you should, if you're going to give it, have your patient or have atropine at the bedside ready to give, obviously on a monitor, and consult toxicology. And I just want to thank Dr. Garlick and Dr. Levine and the whole Docs division for helping me out. Any questions?
Point and a question for the toxicologist. We just had one recently that was a young guy had taken a bunch of Benadryl and he was doing the whole like, when they're agitated, they're not agitated like aggressive, like trying to kill people. They're like picky and just kind of like goofy looking, And this guy was exactly that. He was like hallucinating and sort of goofy and picking around. And we gave him, we called him tox consult. We had, I think it was Michael Bean, told us to give the Physo. We gave the Physostigmine, and within a few minutes, because we saw him when he was well, and then we saw him go into it. And as soon as we gave him the Physo, we're like, hey, you remember why you were here? He's like, oh yeah, of course. So like he was talking just like he was right before we gave it to him. And then within an hour, he went right back into it. As it wore off. And it was neat to see, but we actually didn't redose it. And we brought up that question whether or not it was worth redosing. And we were told that no, we didn't necessarily need to. Are we redosing? Oh my God.
So there is some data in the Harrisburg studies, a lot of cases where they redose, and they actually perform doses. I think there's a little bit of one of the numbers, but you can certainly get agitated from there, like when being agitated, not just like being agitated, but they almost never get as delirious as they were initially. So there are people that die in restraints, just restraints, not related to this, but just patients that are agitated delirium with restrained die. So that's in my mind one of the reasons why I do it. Even if you know there's not a diagnostic history, you know that you can take much Benadryl, but it helps if you need to avoid having to be fighting against restraints. It makes some sense in my mind. They're usually not as agitated on subsequent doses. So if you need to take in people, but it's rare. So probably people who take hijack and get redosed twice.
Just because they were so agitated. Because this guy was pretty mellow.
Yeah.
Yeah, I had a case when I was an intern way back where it was a tricyclic overdose, and the attending decided to give 5 milligrams of physostigmine, which is what was recommended at the time. And the patient then went from sinus tachycardia and paraded through every arrhythmia, including asystole. When we ended up doing CPR on them, and eventually they came back as the physostigmine wore off. But it's always made me a little reluctant to use physostigmine in a situation where the patient's going to get better with nothing.
And then one time when I was a resident, I wanted to give physostigmine, and Ed was my attendant. And he wouldn't let me.
I mean, you have to gauge how serious an overdose is this, and are you going to expose the patient to something that can make them seize and can have
used to be like the theory, people would do it sort of diagnostically. Oh, my patient's kind of delirious. Why don't we try some of this? It was given like water very frequently, and it was specifically given to TCA overdoses because there's an anticholinergic component to TCAs. But that's a perfect example of how there's these a few, and it's isolated case reports of people who were profoundly TCA toxic with evidence of sodium channel blockade with wide QRS who were in status, who were given the thing that we often gave TCA overdoses for, these horrible effects. And I think that became publicized in the paper that Amy mentioned, the Patel paper in the 80s. And then everybody stopped giving because there was this fear, oh my God, we're going to cause everybody to stop. Their heart's going to stop and people are going to die because we're doing this. And so now it's really, really unusual to see people given. But I think if you're aware of the limitations and aware of the times to not give it, like don't give it to TCAs, don't give it white QRS, don't give it to the people, but they're like Benadryl with purely anticholinergic or Jimson weed. If it's pure, their risk is really low. It's a pretty safe medicine. And whether it's going to be a life-saving thing, if they're just like a little bit delirious, like yeah, it's probably not the means to do it. But if you're considering like LPing a kid or CTing somebody, then they're fighting restraints, and you know that it's safe when you meet those parameters and you push it nice and slow, then it's reasonably safe medicine.
I guess that was my question though, is that can you just talk about, since there was no diagnostic uncertainty about what he took, and what was the rationale behind giving it? I mean, is it more just to see if he'd respond, or?
He was agitated and restrained.
Okay.
I guess the article we were just talking about, that was Mike Burns' article. It was retrospective, but presumably, because it was retrospective, those who got Pfizer were sicker than those who got benzos. Yet, despite that, they got out of the hospital faster. They had shorter admission rates, less admission rates, shorter lengths of stays, less intubation rates by giving Pfizer than those who got benzodiazepines. And that's the only study that's looked at benzos versus Pfizer formulation.
All right. All right, let's take 10 minutes. We'll reconvene at 10:05.